I mentioned a second time that we will hopefully have a set of remarks from African and particularly Kenyan scholars on maternal health that are part of a larger two and a half day session in Nairobi that is featuring scholars, practitioners, MPs, and politicians, as well as a large media presence. And so we'll be sharing some of the media coverage of the sessions there with you as we go forward after this meeting. It is a set of topics, maternal health, obviously, that you can take in a lot of different directions. Based on those conversations in June and then subsequent ones, our partners in Nairobi asked for us to focus this session and the session they've been having on improving health systems through a maternal health framework. And so it's been a systems focus. It is one where we have shared with you. I want to just clarify why there are two participants lists. One is for who's in the room here, and one is for who's in the room there, in hopes that making some networking contacts will be useful for you as well. It's certainly been one very kind of rich set of discussions with folks over there. The series itself, our Advancing Maternal Health series, is very generously supported by the Maternal Health Task Force, as well as UNFPA, and getting also advice and support from USAID. And so it is terrific that we have been working with those partners now for going on 2 years and hope to continue to do so next year. In December, Wilson Center's Global Health Initiative will be publishing a summary of the major lessons from the last 2 years. And in fact, Meg Green, who is here somewhere, thank you. Meg is working with Kaylin and helping us do that. And so we very much look forward to that documentation of the very practical and specific lessons learned from these series. If you've had the opportunity to attend some of those meetings last year and this one, you know that we have had the broad 30,000-foot view policy discussions, and then we've had some very focused technical discussions down on kind of day-long sessions on transportation and referral questions and such. And so we've really been able to get very specific as well as look at the big picture. The slides and the various resources from those meetings are on the Wilson Center site now already, but we will put that together in a policy-friendly and accessible document so that you can all take advantage of it in that way. John Townsend is very kind to, as I say, come back and share his thoughts with us on presentations that we hope we will all hear. John was here in June and did played that same role to great effect in terms of putting some of these the presentations from Kenya in a context that connects to both the U.S. and the Washington policy discussions, the larger international community's efforts in these, and gives us a good opportunity to understand these presentations in the larger context. John, as you I think know, is Vice President Director of the Population Council's Reproductive Health Program, and has been in this field for quite a long time, and this just brings tremendous amount of experience to the discussion. So we appreciate very much his coming. Again, that is just about the extent of my preliminaries. We may also have the Wilson Center President Director Jane Harmon poke her head in and to say hello. We'll see if that fits with her making informal remarks or not. But Jane kindly opened the first session that we did in June and spoke passionately about maternal health, both in terms of as a former member of Congress and a policymaker, and also as a mother and a grandmother. And so we hope that she will stop in, and we particularly hope the webcast will be working by then, if she does.
Maybe I could ask another question. How many people have heard about this thing called the diagonal approach? Is that something? It's something. Julio Franco is the dean of the School of Public Health at Harvard, and the kind of interesting thing about Julio is he grew up in Mexico, was head of the equivalent of the National Institutes of Public Health there, and then became the minister. And during that time, he developed kind of a social insurance program. And what he found, I think, during those experiences, and then later on when he went to WHO to work there, kind of reflected on the way health systems operate. And they're kind of two traditions. One is a vertical tradition, and you can think about that as like smallpox eradication. You know, you take everything that you need to do, and you focus, and you kind of forget about that. The more recent metaphor, you can think about as HIV. You know, where PEPFAR, you'll have state-of-the-art labs, for detecting CD4 counts, and then you won't have anybody with a blood pressure instrument next door. So, it's a focus very deep on changing a single outcome. The alternative is people who say, no, let's do health system development, and they think about this broadly. And health systems include not only the public system, but private systems, and it's linked to everything else that affects health, including agriculture, education. And that often leads to a rich conceptual understanding, but not much in terms of operation, because it depends on so many things. What Julio said, and what he tried to demonstrate, I think, in the social insurance scheme in Mexico, was he said, let's try a diagonal approach. And the diagonal is a metaphor for identifying priorities and let those priorities guide how you go about both focusing and addressing that priority, whether it's HIV or maternal health or so on, while at the same time you're checking, how is this doing, how is our efforts, how are they related to these other elements that we'd like to pay attention to. And if at the same time you're dealing with that priority and working along that diagonal to make sure that all the other elements are not being hurt by it, that's his metaphor. He seemed to be able to do it fairly well. What they were able to do is in Mexico is reduce maternal mortality. They had some significant effect on poverty, because part of the social insurance scheme was getting money to families that had a demonstrated need, and they also were able to do this at a scale. So while most vertical programs could be national and they go very deep, most horizontal programs kind of are policy level, conceptual, because no one's really responsible for them. So this diagonal approach allowed him to get governors involved, governors of states, to get it made sense at district level. It made sense at a state level. It was a key focus for federal priority setting. And the additional piece that he always mentions is evidence. Having evidence essentially allows you to set priorities about what are those things that affect health, well-being, and development using evidence, and then you can track, are we any better based upon that? And that tracking allows governments and systems to make adjustments. It allows you to figure out what would it cost to do better. It calls for, I think, also the question of how do you build capacity. I'll bring this up later in the comments, I think, with our colleagues in Kenya. But since he's a teacher, he always thinks about little rhymes here. He has one that's called ABCDE. Think about an agenda, which is defining priorities. Make sure you're thinking about budget. Develop capacity. Think about deliverables. In other words, products. We aren't just putting money into things, and add evidence to that. So it's kind of an interesting way of thinking about it, and it's something I think that is evident in some elements of the global health initiative of the current administration. So thinking about what are those global priorities, what are those principles that allow us to think about these, and how do we move through improving child health and maternal health while at the same time developing country ownership, preserving and keeping women and their development at the center of these initiatives, making sure that we're held accountable for the things we do, and that accountability requires evidence and also a sense of leadership and responsibility. So it's kind of an interesting way of thinking about this, and it's a terrific heuristic for people who will be moving into policy positions, or like you, involved in discussions with policymakers in the next couple of years.
You want to get your first name right.
That's okay. I've been called worse. Jeff.
Well, John, thank you for riffing on that theme. How far along are we in deploying that approach? Is this?
Well, he gives those talks all the time, and everybody who's going to Harvard, I think, I haven't gone to Harvard, but everybody who does comes out of there saying, "Oh, this is how it works." I think that the term diagonal doesn't have any intrinsic meaning, and so it takes a while for people to capture it. There are some, I think, readings that Tim Thomas put into this that would give you kind of a sense of how it works. I think as programs get closer to, as we get closer to the Millennium Development Goals, people are beginning to see that the things that they would like to do depend on linkages with other sectors. Mm-hmm. Let me give you an example. A long time ago, the maternal health field, you had obstetricians who wanted better delivery, and you had nurse midwives who wanted to get coverage and cultural acceptability. So you had this fight. It's like the beer ads. Less filling, more taste. There was no way of winning that. And so I think what the task force has done has gone in and said, look, we have lots of different voices. Let's figure out some ways that we can figure out what those priorities and understand what are those things that lead to maternal outcomes that are undesirable. Oh, they're having fun. This is the Kenyan wedding film.
Yeah. All right.
While they're getting ready, I could just give another example. Family planning was never on the agenda for maternal health for a long time. In fact, it was thought of as antithetical. And so when people began to say, well, up 25 to 30% of maternal deaths could be avoided if those women who didn't want to become pregnant had the means to ensure that they didn't. So we can say, well, gee, is there a single intervention that would reduce maternal mortality if it were used at that level? Well, not really. But you think about, you begin to add those up. For example, another cause of maternal mortality is abortion. Well, thinking what would we do to be able to make that abortion safe or unnecessary? So think about the consequences of that for family planning and for good counseling and so on. Other things like magnesium. Hypertension in pregnancy, so eclampsia, preeclampsia. What are the things you need to do to be able to identify women who might be at risk for this? How do you get them to a first facility? How do you get loading dose? And then those issues begin to become clarified as you look at the whole health system and how it operates.
Mm-hmm. Mm-hmm. Do John's comments spark any questions or comments from the audience that we can have our own little discussion here as they obviously continue to try to get things to work? Yes, ma'am, in the back. I'll grab a microphone for you. I'll play that role. My colleagues who would do better trying to get this over with.
Can you hear me? Oh. How you doing, John?
How you doing? Good.
Hello.
Good. Perfect.
So I just wanted to know if you could give more examples of what countries or even district level within countries that have really embraced the diagonal approach. Because a lot of the research that I'm looking at is there are a lot of gaps in knowledge around how best to do it. Because there are so many factors involved in terms of, supply chain management and resources, human resources and supervision. And so if you could just really expand a little bit more about the diagonal evidence around that.
Yeah, since the diagonal approach is really a metaphor, it isn't something you actually adopt. But I think if you look at elements of what a diagonal approach would imply, Certainly, there's an increased need for and use of evidence. The number of assessments that are going around, both about maternal health and increasingly maternal morbidity, are really informing what needs to be done, how it might be done. I think issues around budgets are becoming clearer, and budgets imply both human resources. When we know more about the lack of coverage of skilled attendants, the implications in terms of quality of care in facilities when people are going to facilities, I think we begin to build on that approach. And I think those countries where we've seen drops in maternal mortality or increases in skilled attendance at birth, family planning, postpartum, more than 3 antenatal care visits, and an effort to have some continuity of care in postpartum, I think we begin to see elements of that diagonal approach going on. Whether they're systematically doing it because they understand the metaphor, I'm not sure, but they're building on that, and I think it might give them, policymakers and people who are thinking about planning, a roadmap to where to go for the next issue. You bring up a good issue about districts. Are we starting already?
Well, let me just check. I don't want to interrupt you. Kaylin and Sandeep, can you hear us there? And importantly, can we hear you here?
Can you hear us?
We can. It'd be great. We've done the introductions here, and John has very kindly been riffing on some themes that I think he was going to share with us after, as well as some others. So if it works for you, I suggest while we have the link that we turn the floor over to Professor Jeffrey Osagie, who is a lecturer at University of Nairobi, to get us started on your end. Does that work for you?
Yes, it does.
Okay, why don't we rock and roll and get started. And Paul, in the booth right now, we see on the screen us here in D.C. If it's possible to go back to the screenshot from Kenya, that'd be terrific. I should say, while you're doing that, it's terrific to have our president and director that I alluded to, former Congressman Jane Harman, would stop in and say hello, as I think those of you who are veterans of our first session in June, you heard her open this session with both passion as well as detail on this issue as a policymaker, as well as a mother and a grandmother. So, Jane, thank you very much. We've been having a discussion here mostly in Washington as we get the technology working. So we're going to turn the floor over now, if we have the audio working, to Professor Jeffrey Osagie, who is a lecturer at the University of Nairobi and who was our counterpart chair in the first meeting as well. So, Jeffrey, are you there?
I'm here.
Sir, the floor is yours.
Director, Madam President, and the panel in Washington. Welcome to this dialogue session on improving health systems through a maternal health framework, which has been held at Serena Hotel, Nairobi. The first day is today, the 17th of October. We shall be having the concluding session tomorrow with policymakers and the media. This first day brought together 55 participants drawn from the academia, research institutions, healthcare providing agencies, the media, and tomorrow, as I mentioned, policymakers will be joining us. The objectives of today's session were as follows: to identify maternal health indicators that could guide the priority setting health systems in Kenya. The second priority was to discuss how maternal health indicators will help to develop health policies and increase funding. And the last objective was to examine opportunities available for researchers and funders to coordinate synergies and to strengthen the health systems for improved maternal health. Madam Director, Mr. Director, and Madam Vice President, the papers that were presented today, which guided the discussions, were on the indicators for maternal health in Kenya, and we had several presentations. Madam Kalin from the Washington, the Woodrow Wilson Center, Dr. Alex Eze from the African Population and Health Research, and Dr. Emera Ara from African Population and Health Research Center discussed various ways through which benchmarks could be set to meet the MDG targets. They noted that MDG 5 targets have largely been missed by Kenya, and that the country appeared to be wide off the course in meeting these targets. And that's why this meeting or this session was important. It was hoped that the outputs of this dialogue will go a long way in energizing efforts towards improving the maternal health systems through the maternal, the health system through the maternal health framework. Now, the forum later on divided into 3 groups to address the broad areas, namely diagonal approach to defining priorities. Then we had the second group that discussed knowledge gaps and the necessary or required research. And the last group discussed the role of policymakers and funders. I want to take this opportunity to invite Dr. Remare to give a 5 or 10-minute brief on his presentation on improving health systems through a maternal health framework. Dr. Remare, please. Okay, it appears he stepped out briefly. Is it?
He's here. We're just going to skip presentations and go to small groups.
Okay. We have decided to prioritize the group work before we move to Dr. Rimera. So I invite Sylvia Shuru, who was a team leader for Group 1, and she will be giving a brief on the diagonal approaches and definition of priorities.
Jeffrey, I'm afraid we may have lost your audio.
Can you hear us?
Yeah, we heard that, but otherwise it's gone silent.
You need to speak up.
Speak up, please. My name is Sylvia, and I'm privileged to give a brief on the discussions that we had in our group. We were discussing the role of policymakers and funders in improving or strengthening maternal health systems. And when we looked at one of the things is how do we involve policymakers and donors in efforts to strengthen the health systems. And one of them is engaging them in forums like this one, so as to share findings, for example, to share lessons learned. And at the same time, the policymakers, we wish them to take a front seat when it comes to the implementation of the recommendations that we come up with. The other thing we were discussing is how do the Ministry of Health and the Ministry of Finance in our partners, how do we work together in strengthening the health systems? One thing is participation in forums, in research briefings, for example, policy briefings, whereby when policymakers and partners come together, at the end of the day, when they meet with the Ministry of Health or Ministry of Finance, we are able to incorporate some of our solutions, like some of the solutions that come out from this program in their planning. Yeah. Therefore, partners, we need to understand the planning cycles of our ministry so that they can include them in their budgets. The other thing is that in Kenya, we are one of the signatories of various international declarations. So in one of them, like the Abuja Declaration, it states clearly that 15% of our national budget should go to health. However, it's not the case currently. So we need to have an analysis of flow of money from the Treasury so as to address the absorption capacity, because we find there's a lot of money that goes back to the Treasury. Then research institutions, we need to work with the Ministry of Finance to assist them to equate maternal deaths and child deaths to financial loss. Because you find the finance department, for example, when it comes to programming, it's not easy to equate some of these things when it comes to funding some of these projects. The other question is, we're looking at interventions. What are some of the things that we need to do or what are some of the things that policymakers and development partners need to do? And we looked at several points. One of them is we need an advocacy package, because we are looking at, when it comes to HIV and AIDS programming, for example, we have several people who champion particular aspects of the programming. But when it comes to maternal health, we don't really have. But therefore, we need an advocacy package whereby it has information that is evidence-based. We need to package our messages well, and we also need to know the processes from community level up to the national level. The other intervention we were looking at is adaptation of a diagnostic approach in reviewing the building blocks for health system strengthening. For example, identifying the strategic partners. Once we know who are our strategic partners, when it comes to service delivery, it becomes a bit easy because you are able to know who's supposed to do what. When it comes to funding, which priority areas need to be looked at first. The other area of intervention is capacity building of health service providers, whereby we're looking at training of our health service providers, and also inclusion of furnishing the facilities with equipment, whereby we need to strengthen our facilities. And then demand creation should also be another area of intervention. And then results-based financing should be holistic and equitable. And the last point in the intervention is increase of the number of health facilities offering maternal health services, whereby we need some facilities, increase of facilities operating 24 hours. Because it was noted that you find in Kenya, most of our emergencies happen at night, and you find some of these facilities are not operating at that particular hour. Our last question was, or discussion, we are looking at health indicators. What maternal and newborn health indicators should policymakers look at? And we mentioned 3 key ones. That is, 1, the number of pregnant women attending the 4 antenatal care visits. That way you are able to monitor. And then percentage of pregnant women covered by NHIF. And the last indicator is percentage of health facilities with access to an ambulance or emergency vehicle. Thank you very much.
Thank you. You can clap on this side too, so they can.
I want to introduce Dr. James Warriero. He belongs to the MDG Center for East and Southern Africa, and he's going to give you a brief of the discussions that were done by Group 1, and that was on diagonal approach and the definition of priorities.
Yes. Thank you very much, Mr. Chairman. And thanks to the panel from the Woodrow Wilson Center. The first question that we covered in diagonal approach and defining priorities was this: using the diagonal approach, which maternal health interventions can best set priorities for strengthening health systems in Kenya? And we looked at three major points. And the first one was the personnel issue, human resources for health. We looked at how these impact maternal health, but also how these, if optimized, would have an impact on the wider health system strengthening in Kenya. And so, of the points that came up under the issue of human resources for health, the first one was in terms of the appropriateness of the training. The training, we felt that people should train more for the job that they do rather than just for the profession. And in certain instances, training needs to be devolved to where it's needed so that people are trained, especially those who might serve in certain marginalized areas. And that sort of brings me to the second issue that we discussed, the issue of retention of health workers in certain areas, because there are these marginalized areas where people don't like to go, and when people go there, they go there for short duration, while half of their time there, they're actually trying to make an effort to get out of that. And so we felt, again, that selecting people from those particular areas, providing training to those persons that's appropriate to the tasks that we want them to carry out, would be an effective way of dealing with this issue that will strengthen human resources for health in general and for maternal health in particular. Then the third thing that we talked about on the human resources for health was the issue of task shifting, of certain responsibilities that can be reproducibly performed at lower levels, at the level of the community instead of at the level of the dispensary or health center, or at that level instead of at the level of a higher level facility still, that those tasks can be shifted to that level. We also looked at the possible role of certain resource persons within the communities, such as traditional birth attendants. Like if there are certain roles that can be fashioned for them to support maternal health, and that might have a certain positive impact again on other areas of the health system, such as being delivery companions, for instance, or women who come for delivery, following up women during antenatal care and during the postnatal period, and being possibly the second pair of hands if they're given some basic training in the delivery room in places where you have only one midwife, who will at certain times have to choose between attending to the new baby and the mother. That these sorts of things would optimize further situation with the staffing at that level. Then we also talked about community midwives, and this is a strategy that's been used in certain parts of the country and certain programs, where retired midwives who come back to the communities where they hail from are then recruited and are supported to provide certain services, especially towards increasing the proportion of mothers attended to by a skilled birth attendant at the delivery. Then the next thing that we discussed in the human resources is integration of services, especially in vertical result areas that may target the same persons but have very variable indicator performance. So you might find, for instance, in Kenya right now, the proportion of mothers who make at least one visit to the antenatal clinics is very high. It's in the 90s, while there are certain services that suffer. And so it might be a good time also to take them to some of these services. Then we talked about equity in distribution of personnel, and also linking human resources and also other resources in terms of commodities, equipment, to outputs at different levels of service provision. so that any improvements that are made in service provision do not result as in quantitative increases in service provision, do not end up resulting in reduced quality of care at those levels because of constancy of the resources which are supposed to be used to provide those services. Then we also talked about accountability at different levels of care provision, especially as relates to the persons providing services, the persons supervising things like commodity distribution and stuff like that, and also even funders and donors. And so having integrated sort of quality of care assessment or measurements that ensure outcomes remain favorable, and the political will that sort of pushes such things to measure accurately what's happening and to incentivize and disincentivize as appropriate certain practices and outcomes. And then the final thing that we discussed in the human resources was sensitization of persons towards a right-based approach in the provision of healthcare at the lowest level of services is another of the interventions under human resources that will improve maternal health, especially with sensitization of the staff, but also the education of the community to know what to expect, to know what the right is at that level, and that its benefits to maternal health will again spill over to other areas of the health system. The second thing that came up as human resources was commodity security interventions or supply chain interventions. And again, the major points that were discussed were that we try to ensure accountability and political commitment and leadership so that these systems work efficiently, there is very little bureaucracy, and so that we do not incentivize verticalization of programs where you find different programs want to deliver their own commodities in a way that's not very efficient and that ends up spending a lot of money because they do not trust the unified distribution system that the country is using to deliver those commodities to the most distant areas. And that has to do with also increasing the capacity in these health facilities to be able to pull commodities as opposed to the current push systems, kit systems that do not take cognizance of epidemiological nuances in different areas where you might find that the one-size-fits-all doesn't really work. Then we also talked about the use of technology to support commodity security and use of health management information systems to support rationalization of quantities of commodities that are sent out to health facilities to ensure that services are provided continuously. That these would have a benefit again for maternal health as a specific intervention, but also cuts across and benefits other parts of the health system. The last thing that we talked about on the commodity was technical infrastructure, especially infrastructure that supports transport and communication systems for referrals and for stuff like that, but also, and in fact, under community security for delivery of commodities, ensuring that these places are reachable and that these commodities can be delivered to those sites efficiently. The last thing that we discussed, and this another wide topic, was male involvement. That male involvement in maternal health will have benefits for the health system and will have benefits for child health and for other issues, because it will also probably improve care seeking for the men themselves. This is an area where little headway made in Kenya in particular, unlike some other countries in the region. So I will move to the second question. And, do bear with me if it's rather lengthy, because the third and fourth questions are very brief. The second question was, how can maternal health indicators be used to create entry points and development plans improving the health system? And the second part of that question was maternal and newborn health indicators should be prioritized. So there was some clarity lost in the language of the question, but we interpreted the question to mean that we want to interrogate how certain indicators for maternal health can be used to link to other things that help improve the health system. And then, of course, the priority indicator, the second part of the question, is pretty clear. So one of the first things that we looked at was one of the indicators that really is very good, the factor visit. So that I already said earlier is in the 90s. It's usually very high, and we felt that it was possible for this to be an entry point for more comprehensive maternal health services, might also be an entry point for other services. And things that we discussed were the possibility of using checklists at that visit to sort of just make sure that things that we do during that visit are reproducible, doing these things consistent, and we're not missing anything. But there was concern also that might make the visit very long, make it difficult and impractical, in fact, for some places where you might find that there are small numbers of health staff. But for that, we also felt that might be a point of referral. At least by then we know the denominator of mothers who are coming in, because it's pretty close to 100%. And so even if we refer them back into the community, for community health workers, we do follow-ups.
Sir, can I interrupt for just 1 second? You mentioned a specific indicator you recommended, and the link just modulated it, so we didn't understand. Could you just repeat what indicator it was that you were recommending to capture that?
Before checklists.
The indicator was persons who attend at least one antenatal visit during the course of a pregnancy.
Thank you.
Thank you.
And that proportion is very high. We felt that the fact that it's that high provides an entry point for other services that might not be getting delivered to sort of that level of success to probably be delivered. And also perhaps even for greater friendliness to ensure that that subsequent visits are actually adhered to by the mother for the dates that they are given. So the checklist issue, if that wasn't clear as well, was that we use checklists to ensure that all the things that need to be done during this visit are done, so that we are using that visit to ensure community health education, using that denominator of mothers, because we know these mothers have come in, so we know who we expect to be tracked within the community. We felt it was an opportunity for some of these services. Then the other thing was we looked at linkages between certain services, especially services that emphasize the continuum of care. And we noted that in Kenya now, they have moved away from cards, from the sort of patient health records where every child would have their own card on which their growth is tracked, on which all their health issues are tracked, to one mother and child booklet that will then carry the history of the pregnancy, have the delivery and issues to do with the baby, and then have subsequent pregnancies as well. That it actually helps us to then have a good longitudinal record of a mother's birth history, and for all the benefits that might help us provide to the mother through the health system. Then the other thing that we looked at was the indicator of skilled birth attendants, the proportion of deliveries attended by skilled birth attendants. We felt that some of the interventions that come under this indicator, some of the interventions that are done, for instance, the community midwives that I was referring to earlier, they may inform certain interventions. For instance, if we felt that if you have these community midwives, the retired midwives are in the community, they're providing this sort of support, they're doing deliveries within the communities where health facilities are not accessible, that it might be an opportunity to link them further to other things like the community strategy that's being discussed and sort of being piloted in Kenya now, where community health workers, or less around a healthcare provider, usually a public health officer or a nurse, called a community health extension worker, that we could use this person as that community health extension worker, and then have additional benefits on top of the maternal health benefits of having such person. We felt that it might also be able to help improve referral systems as we're looking at skilled birth attendants or increasing the proportion of deliveries attended by skilled birth attendants, that we're able to improve referral systems that have a more general benefit, and also that it will help us to then constantly be looking at secondary level infrastructure, like in places where we would need to have cesarean section capacity for referrals from the primary health facilities where there are complications. So in terms of the priority indicators, we felt that looking at perinatal mortality will be it's a priority indicator to look at, because it will help us to look at the quality of care around delivery. And the other one that we thought to look at maternal deaths, and especially in carrying out maternal death audits, and in the way that would help us to look at the weaknesses of the health system, and correct those things, then it ends up having a benefit beyond maternal health. The third question was, should improving the health system for maternal health start at the district level? And here we noted that under the sort of new dispensation that Kenya is stepping into, that this would be called county level. But we agreed that, in fact, it should start at that level, and it'll be able to improve health systems all the way down to the community level, because that will also be the level from where, as the community strategy we were discussing earlier, will be managed. So it is sort of a natural place that's close enough to the periphery from where that could start, but definitely trickling down. Then the fourth question was, is results-based financing an appropriate method to improve health systems for maternal health? Is results-based financing an appropriate method to improve health systems for maternal health? And there, our answer was yes, but with the caveat that there is need for good and possibly independent monitoring and evaluation systems, and audit systems and review, so that we do not end up incentivizing falsification of records or just careless M&D, where people do not look too keenly at things that might reflect them in a bad light, because their financing is based on certain outcomes. So that is what we discussed in Group 1. I would like to invite any of the other group members who may have a clarification around an issue to make it then at this point.
Director and Mr. Vice President, I want to present to you Madam Dr. Christine Kisaka. She works with DSW, and she was the team presenter for Team 2, which was looking at the topic, knowledge gaps and research needed. Welcome, Dr. Christine.
Thank you so much. Thank you so much for this opportunity to present on behalf of Group 2. Our major task was looking at the knowledge gaps and research needed in health system strengthening for maternal health. We basically focused our discussion on 6 health system blocks, and our action points were basically on the 6 building blocks. On the information, which is the first building block, we pointed out that strengthening the community strategy, which is a document and a policy being implemented in Kenya, as an information medium, so that we are able to synchronize the information coming right from the community all the way to the national and to the national data system. On the second building block, supplies and commodities, our major action point was to ensure the harmonization between the planning of these supplies and commodities and their implementation of the same to the community level and down to the health facilities as the community. On the building block of system service delivery, we deliberated and came up with the point that we need to address the inequalities in the distribution of health services, because we find that distribution of health services is skewed towards probably the urban and more concentrated centers in without taking into consideration the slums and the rural settings. And the health financing as a building block, we had two issues to deliberate on, and we majorly said that centralization of health financing was important, so that the finances, both from the national level through to the community level, are decentralized and there is no holding of funds at one level. Also on health financing, we discussed about the empowerment of households on health financing, in particular the empowerment of women and men, so that they are able to plan their finances to see what is allocated to health. Under the health system building block of health workforce, we saw that there was a mismatch between the health workers who are in high supply in Kenya and the absorption or demand at the health facilities. So our recommendation to balance the supply and the demand, so that those ones who are in high supply will be able to come into the system and assist this system. On leadership and governance, our conclusion was that since leadership cuts across all the building blocks, it should be mainstreamed within the maternal health system. On the second part of our discussion, the question was what additional research is needed to evaluate how the health system can be strengthened to improve maternal health outcomes. And what we came up with was that we needed to contextualize the existing body of data. Our group deliberated that we have lots of research, lots of works that have gone down through the researchers and the academia, but we need to contextualize this data for decision making at all levels. The third question we were looking at was what opportunities are available for researchers and funders to better understand and coordinate synergies to strengthen health systems in maternal health communities. Our discussion centered through the health management information system, and we agreed that we needed to strengthen this system and utilize the data that this system is available, that this system is collecting and coordinating. Our second part of that discussion was to harmonize the e-data, including the mobile health data that is available in Kenya, so that every organization or every person involved in e-health should be brought on board to put all this data and have it harmonized and coordinated. Our fourth question was this result-based financing and appropriate method to improve health systems for maternal health. Our conclusion was yes, it was appropriate, but we had one additional factor to this, saying that it needed to be implemented within a structure which is clear with policies and guided clear indicators, so that we all know what we are looking for at the result-based financing. Our final question was, should improving the health system for the maternal health start at the district level? And our conclusion was that we would not like it to start at the district level, we thought the district was a bit too high, and we were suggesting that it starts at the household level so that we have opportunities for male involvement in the house. To also, when men are involved in maternal health, we observe in the other countries that there is improved maternal indicators. And that is why we were saying we would like to have it start at the household level. And that is all what we had to discuss at Group 2.
Professor Geoff Dabelko, Director of the Woodrow Wilson Center, and Professor John Townsend, the Vice President of the Reproductive Health Program at the Population Council. As you've heard from our team leaders, we had a very healthy discussion on those three thematic areas. And just to give a conclusion to it, some of the issues that were raised are some of the issues that in this country have been swept under the carpet. For instance, the role of men in maternal health, as well as the issue of whether the country should move towards popular litigation for improved maternal health. So I want to give this opportunity to the panel in Washington to give their remarks.
Terrific. Thank you very much, Professor. We appreciate very much those wide-ranging and detailed remarks that really give us a whole lot to think about. And we'll ask John Townsend, who, as you said, is the Vice President for Reproductive Health Programs at the Population Council, to make some initial remarks, and then perhaps we can have an exchange with questions back and forth. So, John, please.
Thank you very much, Professor. As always, the Kenyan team provides a rich analysis for discussion. Just a couple general remarks. I think when we're thinking about the diagonal approach, it's really about linkages. And while we saw in the analysis lots of linkages within the public health system from policymakers and finance ministers down to households and communities, we saw relatively little of that linkage with other systems, whether it's transport or local economy or education. So that might be something that in further discussion we could talk about it. I think the private sector was by and large absent. And the only time I think it was mentioned was in the role of retired midwives. And I think that's an opportunity. And if we thought about retired midwives also as a metaphor, thinking about what other resources are available in the private sector that we might be able to deal with. Healthcare in Kenya has lots of providers from religious groups to NGOs and others. And I think we have to be more explicit, perhaps, about how we'd want to engage with them and what we would like to see from them. Another kind of general comment has to do with kind of the content of maternal health strategies. I think the national strategy is really good. It's explicit. Many of the items that were mentioned, raised by the groups in terms of human resources, in terms of financing, are all there. Somehow the question is, how do you get that analysis down to a level that is operational in terms of budgets, whether that's the district level or the provincial level, figuring out how, in fact, to make these plans realistic. Where do we identify opportunities, incentives, and consequences for failing to act where they might? I think the issue of gender is terrific. I think not only we should think not only about the role of men, but the value of women in society. I think in some ways what we've seen is that, or at least I think it was Dr. Fatala who said women aren't dying of maternal death, they're dying because they're not valued, their lives are not valued. And I think in some ways we have to not only talk about men, but also what is it about the role of women or the value of women in society that allows them to be undervalued in terms of health resources, in terms of transport systems, how women are treated in facilities. There's been some recent work looking at disrespect and abuse, I think, in public facilities in Kenya. That is quite alarming, but it isn't unique to Kenya. I would say you see that in every country, where women have a let's say a lesser valued role. I think we would see that. The other side of that, of course, is the overworked health provider in facilities, and I think the human resource issue is really critical. The question is how. How is it possible that you have a midwife taking care of 15 or 20 women who are giving birth? It's clearly unacceptable. And how do we get that information public, and how do we ensure that policymakers take action on that? Let me see if some other big issues came up. Health information. That's clearly a critical role, and I think we're making strides in the collection of information. It isn't quite clear exactly how that information is framed for local decision making. I think the call to action that the Kenyan working groups made is quite valuable. The question is how to do this. Many of these issues are already explicit in plans, but the question is how do we get policymakers to do that? How do we get intelligent decision alternatives in front of our leaders to figure out what are the best investments given critical resources? I think one of our relators there talked about 15% for health. Currently, the public sector invests about 7% of health, and it's unlikely, I suspect, that they will double the amount of health investments in the next year. So we have to think about how do we bring together investments of families, the state, and maybe employers to figure out how do we bring together sufficient resources to make sure that valuable talent in the workforce, women in the workforce, valuable family resources, as well as the state puts in the resources to make sure that this type of this care is provided. There's lots and lots of areas for comment and discussion, but maybe I'll just start with those. Those are big enough, and then we can get into any of the topics that I think either the Kenyan community or the DC community would like to follow up on.
Okay. Thank you very much, John. So, Professor, if it's okay with you, shall we take some questions here for our for the African panelists, for those of you who are there in Nairobi, and then we can engage in conversation back and forth. Does that work for you?
Yes.
Okay.
Proceed.
Okay, terrific. Well, why don't we take some questions here for our colleagues in Nairobi? Who would like to kick off the floor? Perhaps we'll take 2 or 3 and then give them a chance to respond as a panel. So please, ma'am.
Hi, my name is Nana Sengbende, and I am entering with the UN Foundation Global Health. I have 2 questions. The first one was on the health, the lack of health workers in remote areas. And my question for that is there a government incentive, something that is being done so that people can leave the city to go live in a rural area to help, promote healthcare system to those in need? And the second question is, recently there have been the use of mobile technology, cell phones, to increase the gap to provide information to maternal expectant mother. Is there any project that is being done in Kenya or in the area that use cell phone to give access to women who are pregnant to be able to reach a healthcare provider? Thank you.
Okay, terrific. If you could pass it over there. So just to make sure you heard it there in Nairobi, it was, are there government incentive programs for health workers to live in remote areas? And then a question about projects for mobile health, and particularly cell phone health, to help pregnant mothers. Ma'am, please.
Thank you. I don't know if I should face this way. My name is Wendy Wong, and I'm with APT Associates. We are implementing the Health Systems 2020 project funded by USAID. And my question is in response, or to draw on the response that Group 1 gave to question 1 on task shifting and integration of services. And I'm wondering, in the context of Kenya, what opportunities are there to use an integrated approach to task shifting? And to give an example to illustrate more clearly about what I'm saying is, We often see that HIV services are the vertical programs funded by Global Funder, PEPFAR, and also on a community primary health care level, we see that maybe the HIV prevalence isn't high enough for health workers to spend 100% of their time on providing HIV services. So in order to promote efficiency and mitigate the issue of a lack of human resources, how can where are there opportunities for mergers and integration of services between maternal and child health and a service like HIV services that could be possible in the Kenyan context?
Terrific. Thank you very much. So, integrated approach and task shifting with a particular focus on HIV. Meg in the back.
Hello, I'm Meg Green, and I had a question regarding the male involvement point, which seemed to be a shared recommendation across a couple of the groups. And I was wondering, in the context of, as we were saying, where women are not fully valued socially, what exactly are we talking about with male involvement? What are some of the ideas that you have for engaging men in the context of maternal health? Thank you very much.
Okay, Professor, shall we take those and give you folks there in Nairobi an opportunity to divide and conquer in answering those questions?
Yes, we can take them head on. The microphone will be going around for our experts to respond.
Hello everyone, I'm Charlotte Warren from Population Council, and just to address the integration question, the Ministry of Health has an integration strategy for HIV and reproductive health services, and we are currently working on 2 integration projects with the Ministry of Health on integration of HIV services into the postnatal period. I think Kenya is one of the leading countries in sub-Saharan Africa on integrating those 2 particular services.
Thank you.
This is Leon Bovic of UNFPA Kenya. Regarding the question on government incentives to keep health workers in more rural areas, my experience is with Midwives Project, and we had several instances where we have trained midwives and sent them to the northern parts of Kenya, but it has been, at present, quite unsuccessful, since they have been leaving those areas quite quickly, either because they have gone to urban areas, to, for example, to live in Nairobi or Mombasa, or they have just joined their husband, which it's difficult to keep skilled workers in the north of Kenya. So the strategy now, which UNFPA is working with the government to do, is to look at how we can train local traditional people from the local community and give them and train them for the job at hand, increasing the chance of them staying in the community. Regarding the question about mobile technology, yes, UNFPA Kenya has been looking into technology and using mobile technology for reproductive health, and we have looked into that with Safaricom, and we have tried to map the projects going on. And there are, in fact, quite many. Most of them are aimed not at maternal health per se, but at adolescent reproductive health services. So we have M4M, we have lots of other NGOs running with or without government funding. And they are a first-line service for adolescents to have answers regarding contraception, regarding pregnancy and sexually transmitted. So lots of things going on. Plus, the government has just put down a task force to look at all the different types of choices going on in mobile health. So definitely, this is an area to watch in the future. Yeah.
Wisdom. What do we get them all?
The issue of male.
Okay. Yeah, that's right. Male involvement.
So I think I will cover briefly the issue that Charlotte already addressed on task shifting in the Kenyan context. In addition to the opportunity that she described, I think the community strategy, the use of community health workers, sort of having a professionalized paid cadre of community health workers covering a specific number of households, I think is a great opportunity for significant task shifting of sudden follow-ups and those sorts of things at the level of the community. And possibly, in a wider context than maternal health, there are certain aspects of community-based case management that have effectively been shifted to this cadre of workers and certain private programs. And on the issue of male involvement, you asked what are some of the ideas we have in engaging men. I think there are so many ideas as there are people in the room. But one of the ones that I have seen work for one of the projects that we support is the use of male champions. So you find whatever it is, whatever the positive behavior you want to reinforce, you find persons within that community who are already practicing it, and then support them to become the main advocates of that sort of practice within that community. It comes off a lot better than when we go into such communities and try to bridge the things. So I think that is one of the effective ways to do that.
I also want to, my name is Teresa Salifu. I also wanted to add a few of the ideas for men involvement. We find that many clinics in Kenya at the moment, some of them are not so friendly to men. They're mostly visited by women and children. So some of the ideas is to actually make them attractive for the men who come for men so that they can be able to accompany their partners or spouses to the health clinic, and also have information packaged from the clinics, packaged directly for men so that they're able to engage in discussion with their spouses regarding some of the maternal health issues. Another issue also we think is that to have, in terms of research, to have the voices of men heard in research, because many times we have research targeting women, and it would be good to hear also the men's voices and have a deliberate effort to get there, to involve them in terms of what they think are the health issues regarding women.
Maybe could I add something about it?
Sure.
One of the issues that I forgot to mention that's pretty important is kind of the linking human resource strategies with health results-based financing. The reason this is important, essentially, is you don't get performance unless you have sufficient numbers of people providing a standard of care that's required to provide to have a desirable outcome. There are two types of results-based financing that are I think ongoing in small experiments in Kenya. One is kind of incentives, and that may be incentives to keep people in rural areas or to train people from rural areas and have them stay there. And the second is kind of paying for through vouchers, giving poor women and their families a voucher that allows them to use that voucher to exchange for a service of higher value that would reward centers that both provide good quality of care and provide respectful treatment to people who attend those facilities. Is there anybody who wants to comment in the Kenyan team about both these experiments and how they relate to human resource strategies? In countries where these taken place, if you don't have adequate human resources, you don't actually have the results you'd like, and those financing schemes don't work very well. We have a volunteer.
Regarding the vouchers, Charlotte Warren again. Regarding the vouchers, we have seen an increase of utilisation in a number of facilities by women who have vouchers. And they are targeted at the poorer populations more, so it's reduced the inequities in accessing healthcare. But one of the issues that has happened is that when the public health facilities have an increase in utilisation, they cannot spend the money that they get reimbursed for providing that voucher client. They cannot use it on increasing the skilled personnel, and so then you get a kind of issue where you may have many clients per midwife ratio, and then that becomes a problem with the quality of care.
Professor, were there other remarks from there in Nairobi that we may have missed?
We had a comment, one of our key participants here.
My name is Fred. I just wanted to, there was a question about whether the government had incentives for healthcare workers to work in the... Okay, I work for NGO in the rural area somewhere in Kenya. Yeah. So I wanted to talk something about the incentives that are provided, and I wanted to say that in terms of some of the policies that the government has, this is something that they're put in their policies, and that in terms of training, for example, for medical officers who work in a rural area or in a hard-to-reach area like northeastern or they were offered scholarship for them to train for their postgraduate. However, as time went on, this was something that was not followed through, and nowadays anyone who works anywhere can be trained. So this is one of the areas we will get the government so that it can be instituted, so that medical personnel can be encouraged to work in these hard-to-reach areas.
Guys, just let me know with the hands if are there some more questions here in Washington. Okay, if we could bring a mic, perhaps we'll take a couple more questions here from Washington.
Hi there, my name's Rebecca Husband. I'm from Cardno Emerging Markets, USA. My question is about the private sector, and I'm glad that you brought that up. Just if the folks in Kenya have any successful examples of private sector actors strengthening health systems within the maternal and perhaps child health framework as well, that would be great to hear. Thank you.
Are there other questions here in Washington? Yes, in the middle.
Hello, my name is Laura Divins. I'm with the U.S. Department of Health and Human Services. In light, I know a lot of countries in sub-Saharan Africa have been struggling to reach the 15% target set by the Abuja Declaration. And, you know, we have seen, and this has been a common theme among several government officials that we've spoken to, that a lot can be done with a little, with increased accountability. And I wanted to see if anybody could speak on efforts to increase accountability within the health sector in Kenya to ensure efficient appropriation and expending of funds.
Okay. Other questions? I would just perhaps add another one. I know all of you are meeting tomorrow with members of Parliament and the media in a larger public session to accompany your workshop today. Are there particular issues that you want to put at the very top of what you'll be telling them tomorrow? And I ask that in part so that we know, from your perspective, what the what those priorities are, what those bottom lines are for the senior policy decision makers, so that we can also be aware and be sure to be sharing them on this side as well.
Thank you, Director. Can have some responses. Questions that were raised on private sector role, the MDG 5 targets, and also the priority issues for the policymakers and the EU.
Okay, my name is Caroline Agesa from FHRC. I'm going to talk about the private sector. The private sector is trying, and they're working in conjunction with the NGO. Like, for example, the British American is providing health insurance for a very small fee. For about $5 a month, you can get health insurance and get services ranging from maternal health to community services in the health facility. This is going on in the slums, like in Mathare, and also in the rural areas. They are trying. So, yeah.
Thanks. My name is Rosan Karuga from Family Care International. I'd like to say something about the private sector in the health sector. So, one example is the Population Services International, PSI, which is a social marketing institution and works very well with private providers franchising these private health facilities. And in these facilities, they offer FP services, voluntary counseling and testing, and they're now moving into integrating HIV services into integrating maternal MNCH program into the HIV program program in this network of private health providers. It's called the TUMZA network, TUMZA.
Especially about the priority issues for the media, policymakers.
I'm not sure why Basel is on this forum. My name is Alex Eze, and congratulations to be part of this time. I'm with the African Population and Health Research Center. In terms of priorities, I think a lot of the working group discussions and raised a number of issues relating to human resources for health, issues, integration, health information systems. There's quite a lot that I think it will be a dialogue, and we will raise the same issues we talked about today with them and see exactly where we are. I think there was a question from the Department of Health and Human Services thinking about how do we, given the fact that we've not been able to reach 15% of budget for health, how do we ensure that accountability for resources that is available? I think this is a major issue, and accountability is something that has to be seen throughout the whole system, from the ministry itself at the national level to the facilities at all levels, and to the healthcare providers themselves, whether they are present in the health facilities to offer services when they're supposed to be there and all that. And those are the issues we are trying to deal with. It has to be addressed at all these levels in order to make the best of the available resources to improve child health.
Could I do a follow-up?
Please, John.
Alex, could I do a follow-up with you? Alex, this is John again. The issue of accountability is a really a tough one in every country. And there are three tracks that are taken in some places. One is kind of tracking of performance and public, just public reporting of performance, as well as potentially tracking of resource ability. So places that have few resources shouldn't be called upon to do more than they can. The second is audits. And the audits may be maternal death audits or near-miss maternity death experiences, audits about what did the health system do. And the third is litigation. And recently in Uganda, there was a major case of a woman dying during delivery, and that has hit the press. Of these three things, which of the three are kind of taking hold in Kenya, and what is the role of the media in calling attention to public authorities about either improving performance, the results of audits, or litigation?
Thanks, John. I think the fourth aspect of accountability is really around accountability for resources or commitments that people make, especially developed country partners who pledge certain levels of resources to support development health programs. How well are they keeping those promises and commitments? If we leave that apart and we come into the three areas you looked at, I think in terms of the discussions we've had, at the national level, accountability, I think in terms of if we have X% of our budget going into health, how much of that is actually released, and how do they flow through the system, how are they accounted for? I think that's very central, and unless we strengthen the systems of resource tracking within these countries, the flow of resources from Ministry of Finance through the Ministry of Health, through the health facilities and all that, it would be difficult to see how well are we doing in that respect. So we underscored the issues around health information systems, and I think this would be very central to bringing in, without information, it is very difficult to track performance and to track and to measure accountability. With respect to maternal audits, I think that's one of the key points that has come out here repeatedly, that in places and instances where there has been a system in place to ask questions and to hold people accountable for every single maternal death, for every single stillbirth, especially those that occur within the health facility, that there's been significant improvements in the indicators. So it is important that we recognize that. And how do we do that? I think it requires very strong systems of vital registration, that we're able to register every birth and the outcomes and every death and the causes of death, and be able to ask questions. And this is where the press and the civil society will have to play an important role in bringing this to the and putting the government or bringing it to task in terms of setting in place the mechanism that allow for tracking at those levels. With mitigation, I think here one of the biggest challenges is really for Kenya and for many parts of sub-Saharan Africa is this whole issue of professional, within various professional groups, people tend to protect each other. And it's difficult to get a doctor to testify against another in matters like this. So we need to really understand the legal framework, the systems in place that can allow the society and the public to be able to take action where that is needed. Of course, we don't want to get to the point in the US where doctors to almost handicap implementing specific interventions simply because they are going to be suited.
Thank you.
Jeffrey, do folks there have any questions for John that they'd like to pose from Nairobi to Washington?
Let me ask them to pose questions to Washington. We have
Okay. Maybe my not a question, but I wanted to add some points on in terms of the press, the role of the press in highlighting issues on maternal health. Okay, greetings to the team in the Washington, D.C. My name is Deborah Gatti. I work in the communication department in APHRC, the African Population and Health Research Center. It's a pleasure to have you all and to highlight a very important key issue in Kenya, and especially targeting our mothers and sisters in the country. I would like to say that yes, the media has a great role in this kind of issue, because in Kenya, a big number of the people get information through the media.
and mostly radio, which is listened at a high percentage in the rural areas where we have these services, and in the slums that do not, many people do not have the television, will actually listen. And I'm speaking right now, our meeting today has already been aired in several radio stations at about lunchtime, that is 1 o'clock Kenyan time. And the issues are already out there. And the role we have in the media, the role that the press will play is that when we have the policymakers coming to such forums, then we put them, the media, the press put them to task to ask them, what are they doing? We have the information there. Where are they reaching? Are they aware that this kind of things are happening in the community? And what is the government doing about it? And so they can only highlight the issues and maybe make a follow-up to do various interviews, go back to the slums and see what's happening there, highlight on TV, write on the print newspapers, and air the information on radio. Information is very powerful, and of course, it keeps on changing and depends on how it's reported. In terms of communication experts, we try to give them the relevant and very critical information that we have after research is done, and so ensuring that they report the right thing in the press, in the media out there. So actually what I was going to say is that the media has a very critical role, because what the numbers they report out there and the issues they report out there are the ones that really matter. So we give them the real research that has been done and put them to interview the experts and to see how research was done and how it has been disseminated and what the researchers think and their recommendations. And that they will also interview the policymakers to see how they will take things up. Thank you so much, and let's continue together.
Thank you very much. We were able to share some of the Kenyan media coverage that was generated by the first meeting with the audience here today, as well as, I should say, we were also handed out copies of the PowerPoint that we weren't able to go through for time. So we're sharing some of these reports and insights from there in Nairobi with everyone here. Thank you very much for that intervention on the media. Yes, we were pleased to hear that the insights from your workshop have already been broadcast some hours ago there in Kenya. So that's congratulations to all of you for integrating the media into your discussions so well, so quickly. Professor, are there other questions there in Nairobi that you have, or comments? It doesn't have to be questions, but other comments from your group of experts there?
Yes, we have one from Professor Wellington. He's willing to give a comment or a question. Please, Professor. Yes, please.
Thank you. I'm Professor Wellington Otieno, Executive Director of the Center for Research and Technology Development in Kenya. Now, this is my second time in participating in this very commendable work being done by Woodrow Wilson, together with the African Population Health Research Center. Now, what is very clear is that maternal health can be greatly improved by strengthening health systems, but that is not that will not be the optimal. We cannot get the optimal 100% on that. There is very clear linkage between food security and health. If we empower the mothers and the sisters at household level in terms of balanced diet, which you can only derive from availability or providing food security in the food system, then we are able to achieve some of these goals. And therefore, what am I saying? I'm saying that this is such an important area that we should bring on board other players, other policy research organizations, whether it is on empirical data or it is on policy research, so that we can get we can bring greater bearings on our policy makers, so that they can appreciate the importance, the significance of this area. Once we do that, then you will find that we shall turn around the resource allocation so that we can have a greater impact in this invisible death, I would say. Invisible in the sense that when you look at reports that the journalists make on the traffic roads in Kenya, it was almost on a daily basis, when there is an accident, traffic accident, motor vehicles colliding, 5 people are dying, or 5 people are dead, it becomes a news item. But I know that probably every 1 hour or every 2 hours, a woman is dying during the delivery. And it hardly catches any attention. It's a normal thing, it is invisible. Now, this is shameful. And therefore, I think what I'm pleading for is that we must bring other players, other research players, especially policy research, other policy research organizations, to join the commendable work being done by Woodrow Wilson and African Population Health Research. Thank you.
Dr. Wellington, you're bringing us back to the very kind of bottom line importance in life and death for these issues, and how they need to be not just discussed among those of us focusing on these issues, but with the wider communities, and the opportunities and the necessity of bringing those other audiences and communities to bear on this issue is a very good reminder, and one that I think may be a good place for us to conclude the discussion. I would have said up front, but I'll take the opportunity to say now that we at the Wilson Center and our Global Health Initiative are very, very appreciative of the partnership with the African Population Health Research Center. I know my colleagues Sandeep Banthala and Kaylin Ostrovsky are there, and they would want me to say that it has been a very enriching and productive collaboration, and we appreciate very much all the work that has gone into a second very successful meeting. And as I suggested, we will find multiple ways to share the insights from these conversations, as I know all of you are doing. And I also would hasten to say that we are very appreciative of the Maternal Health Task Force and UNFPA's support for this series and for these meetings and for this partnership, without which we would not be able to have these conversations today. So we want to be sure to thank them. Professor, any final thoughts from your side there in Nairobi?
Let me confirm with my team if there are any final. It appears we don't have much to say, but I want to thank you for granting us an opportunity to share with you the products or the outcomes of our discussion. And I'm happy that what we have shared with you will be used as part of the illumination for tomorrow's conversation with the policymakers and the media. And we hope that you will get a report from the APHRC and also from your team here on how the policymakers intend to take this agenda forward. Director?
Thank you very much. And Jeffrey, again, it's so wonderful doing this with you. You have a way of getting everyone involved there and sharing all the insights from the speakers and then the discussants. We thank you for being so good at doing that. It really enriches the conversation. So from Washington, thank you all very much for staying late at work, so to speak. I know it's quite a bit later there than it is here. So we thank you all very much, and we wish you the very best of luck in tomorrow's discussions.